Hey, this is a review from Class Lecture, Chapter 9 of the Lewis book on pain management. Margot McCaffrey said, "Pain is whatever the experiencing person says it is and exists whenever she or he says it does." This definition emphasizes the subjective nature of pain, in which a patient's self-report is the most valid means of assessment. The description of pain is subjective. Patient's experience and self-report are essential. Now, it can be problematic when dealing with special populations like coma or dementia or really young children. Nonverbal information such as behavior aids the assessment of pain. It is a multi-dimensional experience: physiological, affective, cognitive, behavioral, sociocultural. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So use of a numerical pain scale of 0 to 10 allows a patient to objectively rate the intensity and severity of pain. This tool provides the most accurate evaluation when used before and after pain relief measures are implemented. To assess the quality of a person's pain, you have to have the patient describe the pain in their own words. Magnitude of the pain problem. In an acutely ill patient, unrelieved pain can result in increased morbidity as a result of respiratory dysfunction, increased heart rate and cardiac workload, increased muscular contractions and spasms, decreased GI motility and transit, and increased catabolism. Why pain is undertreated. Many times it's inadequate skills to assess and treat the pain, unwillingness to believe a patient's reports, lack of time, expertise, and perceived importance of pain assessments, false concepts of addiction and tolerance. In addition, some healthcare providers fear that aggressive pain management may hasten or cause death. Negative emotions impair a patient's quality of life, and suffering can result in a profound sense of insecurity and a lack of control. When suffering occurs, people can experience spiritual distress, and studies demonstrate a link between depression and pain. Achieving pain relief is one essential step in relieving suffering. As a nurse, look at their facial expressions. Are they socially withdrawn? Are they less physically active? Include demographics, support systems, social roles, culture, age, gender, education. All of these influence beliefs and coping strategies, and it must be assessed without stereotyping. The cognitive dimension also includes pain-related beliefs and the cognitive coping strategy that people use. An example is some people cope with pain by distracting themselves, where others convince themselves that the pain is permanent, untreatable, and overwhelming. Research has shown that people who believe that their pain is uncontrollable and overwhelming are more likely to have poor clinical outcomes. Families and caregivers influence a patient's response to pain through their beliefs and behaviors. An example is families may discourage a patient from taking opioids because they fear the patient will become addicted. Noxious tissue-damaging stimuli, including thermal, like a sunburn, mechanical, like surgical incision, or chemical stimuli, toxic substances, can cause a release of numerous chemicals, which is what we call the biological soup, like hydrogen ions, substance P, adenosine triophosphate, into the damaged cells. Other chemicals are released from the mast cells, like serotonin, histamine, bradykinin, prostaglandins, and the macrophages, interleukins, tumor necrosis factor. And these chemicals activate the nociceptors, which are specialized receptors or free nerve endings that respond to painful stimuli. In addition to stimulating nociceptors to fire, inflammation and subsequent release of chemical mediators promote lowered nociceptor thresholds. As a result, the nociceptors may fire in response to stimuli that previously were insufficient to elicit a response. They can also fire in response to a non-noxious stimuli, such as light touch. This increased susceptibility to nociceptor activation is called peripheral sensitization. An example is a sunburn with inflammation secondary to a thermal injury can result in a sensation of pain or discomfort whenever the affected skin is lightly touched. There are two types of pain: nociceptive, which is going to be activation of the peripheral nociceptors, and neuropathic, which is abnormal processing of the stimuli by the nervous system. Pain mechanisms transmission. Pain signals are relayed from the periphery to the spinal cord and then to the brain. The nerves that carry the pain impulses from the periphery to the spinal cord are called primary afferent fibers that include the A delta and C fibers, each of which is responsible for a different pain sensation. A delta fibers are small, myelinated fibers that conduct pain rapidly and are responsible for the initial sharp pain that accompanies tissue injury. C fibers are small, unmyelinated fibers that transmit painful stimuli more slowly and produce pain that is typically aching or throbbing in quality. Primary afferent fibers terminate in the dorsal horn of the spinal cord, which contains the cell bodies for the afferent nerve fibers. Transmission to the spinal cord is when the first order neuron extends the entire distance from the periphery to the dorsal horn of the spinal cord with no synapses. So an example is an afferent fiber from the great toe travels from the toe through the fifth lumbar nerve root into the spinal cord. When it's generated, an action potential travels all the way to the spinal cord unless it's blocked by a sodium channel inhibitor, like a local anesthetic, or it's disrupted by a lesion at the central terminal of the fiber by a dorsal root entry zone lesion. So the manner in which the nerve fibers enter the spinal cord is central to the notion of spinal dermatomes. And the dermatomes are areas on the skin that are innervated primarily by a single spinal cord segment. An example is shingles. It is a distinctive pattern of a rash caused by herpes zoster across a back or trunk and is determined by the dermatomes. Perception. There is no single precise location where pain perception occurs. Instead, pain perception involves several brain structures. An example, it's believed that the reticular activating system is responsible for warning an individual to attend to his pain stimulus. Cortical structures are also thought to be crucial to constructing the meaning of the pain. So behavioral strategies like distraction, relaxation strategies are effective pain-reducing therapies for many people. By directing attention away from the pain sensation, patients can reduce the sensory and affective components of pain. Modulation. Descending modulating fibers release chemicals like serotonin, norepinephrine that can actually inhibit pain transmission. Several antidepressants exert their efforts through this modulatory system. An example is amitriptyline, venlafaxine, or duloxetine, and they're used in the management of chronic, non-malignant, and cancer pain. The patient's sleep, though, is not an indicator of someone being pain-free. The nurse may need to wake a patient and administer their pain medication. Pentazocine, Talwin, is an opioid and can precipitate withdrawal if used in a patient who is physically dependent on mu agonist drugs like morphine. Meroperidine, Demerol, is contraindicated for chronic pain because it forms a metabolite that is neurotoxic and can cause seizures when used for prolonged periods. Ibuprofen, amitriptyline, and oxycodone are all appropriate medications for long-term pain management. So here's another look at the spinal dermatomes. They represent an organized sensory input carried by specific spinal nerve roots. The C is for cervical, the T is for thoracic, the L is for lumbar, and the S is for sacral. Because pain is a multidimensional experience, asking a question that addresses a patient's experience with the pain is likely to give you more information. Like, how much pain do you have now is an assessment of the intensity of a patient's pain. Various intensity scales can be used. What makes your pain better or worse assesses alleviating or aggravating factors. How does your pain limit your activities? That assesses the degree of impairment and quality of life. What does your pain feel like? That assesses the quality of pain. The patient is the best authority on their own pain, and the nurse has to be aware of biases and misconceptions about the pain, as well as the pathophysiology and how age, gender, fatigue, culture, anxiety, previous experiences, and coping affect the pain experience. Now, nonsteroidals provide an analgesic effect by decreasing the production of pain-sensitizing chemicals, such as prostaglandins, at the site of an injury. The transmission of the impulses through the spinal cord, brain sensitivity to the pain, and descending nerve pathways are not affected by nonsteroidals. A good question to begin is, how would you describe your pain in order to determine the specific type of pain? So nociceptive pain would be damage to the somatic or visceral tissue, like surgical incisions, broken bones, arthritis, usually responsive to opioids and non-opioid medication. Somatic pain is further characterized as superficial or deep. Superficial pain comes from the skin, mucous membranes, and subcutaneous tissue, and it's often described as a sharp burning or prickly pain. Deep pain is characterized by deep aching or throbbing and originates in the bone, joint, muscle, skin, or connective tissue. Visceral pain comes from the activation of nociceptors in the internal organs and lining of the body cavities, such as the thoracic and abdominal cavities. Visceral nociceptors respond to inflammation, stretching, and ischemia. Stretching of hollow viscera in the intestines and bladder that occurs from tumor involvement or obstruction can produce intense cramping pain. Neuropathic pain is caused by damage to the peripheral nerves or the central nervous system. It is a burning pain. Common causes of neuropathic pain also include trauma, inflammation, metabolic disease like diabetes mellitus, infections of the nervous system, tumors, toxins, and neurological diseases like multiple sclerosis. People who have neuropathic pain say it is numbing, hot, burning, shooting, stabbing, or electrical in nature. It can be sudden, intense, short-lived, or lingering. One particular debilitating type of neuropathic pain is complex regional pain syndrome. Typical features include dramatic changes in the color and temperature of the skin over the affected limb or body part, and it's accompanied by intense burning pain, skin sensitivity, sweating, and swelling. Chronic regional pain syndrome type 1 is frequently triggered by tissue injury. The term describes all patients with the above symptoms but no underlying nerve injury. Type 2 is associated with diverse sympathetic dysfunction. Acute and chronic pain. Examples of acute pain include postoperative pain, labor pain, and pain from trauma like lacerations, fractures, sprains, angina, or infection, or dysuria from cystitis. For acute pain, treatment includes analgesics for symptom control and treatment of the underlying cause, splinting for a fracture, antibiotic therapy for an infection. Normally, acute pain diminishes over time as healing occurs. An acute pain, though, can persist and can ultimately lead to disabling chronic pain. An example is pain associated with the herpes zoster shingles. It subsides as the acute infection resolves, but it's usually within a month. But the pain persists and develops into a chronic pain state called post-herpetic neuralgia. The severity and functional impact of chronic pain often are disproportionate to objective findings. Whereas acute pain functions as a signal warning the person of potential or actual tissue damage, chronic pain does not go away. It's characterized by periods of waxing and waning, and behavioral symptoms include decreased physical movement, activity, fatigue, withdrawal from others, and social interaction. Chronic pain can be disabling and accompanied by anxiety and depression. The treatment is try to control as best as possible. Focus on enhancing function and quality of life. The nurse is responsible to gather and document the data and make collaborative decisions with patients and other healthcare providers. The assessment is an essential, although often overlooked, step in pain management. So the goal is to do a pain assessment through direct interview, observation, diagnostic studies, and physical examination. Before beginning any assessment, needs to recognize that the patients may use other words that mean pain. For an example, an older adult may deny they have pain, but may respond positively if you ask them, are they sore? Are they aching? Document the specific words that the patient uses to describe the pain. Then consistently ask the patient about pain using those words. Pain onset involves determining when the pain started. Patients with acute pain resulting from injury, acute illness, or treatment typically will know exactly when their pain began. Those from chronic pain resulting from failure of the body to heal properly or from a chronic progressive illness may be less able to identify when the pain started. Establish how long the pain has lasted or its duration, and this will help determine if the pain is acute or chronic and will assist in identifying the origin of the pain. So many types of chronic pain, like arthritis pain, which kind of comes and goes over time, a patient may have pain all the time that's constant around the clock, as well as very distinct periods of intermittent intense pain. Episodic, procedural, or incident pain is a transient increase in pain that is caused by a specific activity or event that precipitates the pain. Examples would include dressing changes, movement, changing positions, a procedure like catheterization. Referred pain is pain that is localized in uninjured tissue. An example is angina pectoris is known to radiate from the chest to the jaw or down the left arm. Sciatica is pain that follows the course of the sciatic nerve. It may originate from joints or muscles around the back or from compression or damage to the sciatic nerve itself. Typically, information about the location of pain is asking the patient to describe the site of pain, point to the painful areas on the body, or mark painful areas on a pain map. Pain intensities are the rated scale, 0 to 10. Use observational skills for nonverbal patients. Most patients can rate the intensity of their pain using numeric values. No pain and 10 the worst pain, or verbal descriptive scales. None, little, moderate, and severe. Giving opioid by dosing by numbers without taking into account a patient's sedation level or respiratory status can lead to unsafe practices and serious adverse events. Safer analgesic administration can be achieved by balancing the patient's pain with the analgesic side effects.